talk a little bit about how we diagnose and manage ILDs in general. And there'll be a lot, maybe a little focus on IPF, of course, because that tends to be where we go. But and I'll flip back and forth between ILD and IPF. But hopefully this will be the overview that you're looking for. So so to start with, and just starting with it very much of the obvious, but I always feel it's helpful to kind of come back here, is to remind ourselves that interstitial lung disease is a really, really broad category, right? I mean, it's anything that'll infiltrate the alveoli, the epithelium, the capillary endothelium, spaces between those structures, and the lymphatic tissue. So there's a lot of places where pathology can happen, right? So we might see on a CT scan a pattern of something that's too much white, but reminding ourselves that it could be in any of these particular spaces gives us a perspective of how broad this category of interstitial lung diseases are. And what makes it tricky for all of us is that it's really quite similar. When the patient shows up with you, they look a lot alike, right? I mean, there's the same clinical story every time. They're short of breath, they're coughing. The x-ray, like I said, has some extra white stuff on it. The pathology, the physiology is usually restrictive. Maybe there's a little obstruction for a clue. And then the pathology is really difficult to decipher. So it becomes quite the task to work our way through, these interstitial lung diseases to sort out what it is, and then how we treat it. And so to give you a sense of some of the names of these things, we have, IPF is the one we talk about the most, idiopathic pulmonary fibrosis, but we're dealing with probably more than 150, maybe more than 300 different entities that we can kind of, if you're a lumper, not a splitter, you can kind of drop into three really big categories, of ones that we know about, we can make a cause, we can associate it with something. And then the ones that end up being idiopathic, and we basically diagnose by description. And then the other interstitial lung diseases, sarcoid, and all these sort of orphan type diseases with their own specific names. And that's sort of how we start to group them together. If you think about the epidemiology, it's probably more common than we give it credit for. It's maybe one of the less common pulmonary phenomena that we deal with, but it shows up quite, relatively frequently in our pulmonary practices, with a prevalence of somewhere between 67 to almost 100 per 100,000 per year, and an incidence of 19 to 26 per year. If we look at the breakup of what's going to show up in any interstitial lung disease clinic, or of all your interstitial lung diseases, you'll see that 20% of them end up being IPF. Can you hear me okay?
Yep.
Yeah.
Okay. Yeah, 20% end up being IPF, another 20% are probably hypersensitivity, another 20% the connective tissue diseases, another 20% sarcoid. So that I think resonates with what you're seeing, right? I mean, as you start to work it through, you break them down into these different groups. And then you have the pneumoconiosis, which Dr. Cahill does quite a bit of, actually. And I'm sure, actually talking to you, Megan, you see quite a bit of that, right? Is that right?
Yeah.
In your practices, maybe.
With all the uranium mines and stuff around.
Yeah, I was going to say the uranium mines are down there. Yeah.
Right. You may even have a higher incidence than this classic 10% because of because of where you're located. And then the other ILDs kind of fall in that other 10%. So that's the general epidemiology and breakdown of what we're seeing in our clinics. It's no need to tell you guys this, but I always think this is interesting data, that this is a difficult process, right? So as physicians, and even as pulmonologists, we do a really crummy job figuring out that our patients have this disease. So most patients will tell us from the time that they've had their first symptom to the time that we actually get to the diagnosis, they're journeying through a series of doctors for 1 to 3 years. They're usually seeing at least 2 to 3 doctors before we get to the diagnosis, and they're usually misdiagnosed a couple times along the way. And when we ask the patient experience, no surprise that 97% of them say, we wish we'd done a better job. And so not only, it's bad for the patient, but it's also, bad for the patient experience and sort of, mental health, but it's also bad for their survival. So the sooner we recognize and diagnose and get an accurate diagnosis for the patient, the better we're going to do in treating the patient and helping prolong reduce their morbidity and improve their mortality. And the diagnosis matters because we can see that, particularly in the era of antifibrotics, well, even before the era of antifibrotics, knowing that someone has IPF is a very different prognostic finding. Say, you can see down here where they're going to die a lot sooner than if they have a non-IPF ILD. So telling them what they have and giving them a prognosis is important. And now that we have antifibrotics, it becomes even more critical that we diagnose them as quickly as we can and move them and get them onto the correct therapy to improve their outcomes. The natural history of IPF is, as most of you know, but I'm going to just put this slide in just to sort of tee up the discussion for transplant, is that it's very unpredictable, right? I mean, some patients will have this a very, very rapid course, and from the time we meet them, they're quickly deteriorating and they die. Other people tend to seem to have this really more mild course, and they go well and they stay stable, or they very slowly progress. But most of our patients do this sort of stuttering course where they'll appear to us to look stable and we think we're doing just fine, and suddenly there'll be this acute exacerbation where we'll see this sudden decline in their function, in their pulmonary function, in their clinical status, and they'll be in a worse situation, and then they may again, stabilize, and then they'll have another acute exacerbation. And these will ultimately lead to respiratory failure and death. And because we can't predict these exacerbations, we have to be very vigilant about, setting them up for transplant, setting them up for all the therapies that they may need, so that we're ahead of them, so that we don't, and we also don't have a false complacency about, oh, they're doing just fine, they're stable, we don't need to treat, we don't need to do anything. So understanding and knowing that these exacerbations will ultimately happen, I think does sort of frame how we approach and take care of our patients. So this is the diagnostic algorithm, and then I'll walk us through this and sort of, this is the diagnostic algorithm from the guidelines, and I'll walk you through this and how we sort of do this from a clinical perspective. So if you think about this, a patient might be suspected to have an ILD for whatever reason. You've, as a pulmonologist, you've sort of sorted out that they're coughing or they're short of breath, and you've put this on your radar. And then you start to think about why they would have it, right? So you think about whether there's a potential cause or associated condition. And if so, then you sort of say, well, this is probably a disease from X, Y, and Z, your exposure, your autoimmune disease or whatever. You get some imaging, get a diagnosis, and then you know that it's not IPF and you treat accordingly. When you don't have an associated cause, then this whole algorithm of trying to get to IPF versus something else starts to play in. So you get the CT scan, you pay attention to the pattern. If the pattern is diagnostic of UIP and the patient has no known cause, you can move quickly to a diagnosis of IPF. And those patients are fairly easy to figure out and move on to treatment. Where we get into issues here are these patients that have CT scans that are not exactly perfect for UIP, and we need to understand what, in the absence of a cause, whether we're dealing with IPF or we're dealing with something else that we don't know what happened. So we can use this multidisciplinary discussion, which I'll talk about, and we can use maybe some pathology, and then we can get to the diagnosis of whether ultimately we decide it's IPF or not. So in more simplistic terms, making the diagnosis of IPF is excluding the known cause and having UIP on a CT scan, or having the right combinations of CT scan findings and surgical lung biopsy findings. So how do we do this? These are our tools in our toolbox, really. We've got our history and physical, which we always, of course, do. And the history focuses a lot on exposure assessments as well as autoimmune type symptoms, as well as duration of the symptoms, etc. And we do an exposure assessment, which I advocate for being a very more thorough with a questionnaire of some sort, so you don't rely on your memory. A physical exam that focuses really on the lungs and other systemic diseases that also have ILD as part of them. We have our radiology, which we'll talk about. We have our serologies to look for autoimmune, and we have our pathology. So let's break that down. thinking about our history and physical, you guys are pulmonologists, so you don't need me to tell you that crackles at the base of the lung are the most important finding. But when I do this talk for general practitioners or internal medicine or family practice, I remind them that they have within their power to make that early diagnosis of ILD by just listening to those crackles. So hopefully you're telling your colleagues that as well, that that's really helpful. We focus our exam really on some of the autoimmune findings, so digits and joints and things like that, to oftentimes can make the diagnosis just by finding, say, for example, hand cracking like you see on this patient, sclerodactyly, you know, looking for Raynaud's, things of that nature. So the hands can be, Gottron's papules can be a very good signal to what's going on with a patient. We get spirometry and DLCO, of course, and then the other thing I think it's important, which you know, is checking their oxygen needs and seeing if they desaturate can definitely be an early signal. The exposure assessment is, I think you know this, but just to remind you that we're looking obviously for medication-induced lung diseases, so really being thorough about medications they've been on, and you're all familiar with pneumotox.com. You use that?
Yeah. And we're using I think it's the National Jewish ILD questionnaire. It's like 4 pages, so everybody gets one on check-in. Perfect.
That's great. Yeah, that's good. And that makes life so much easier, right? Because you've got all those, you got to just flip through the positives, right? So then this is, okay, fine. So these are all included on that questionnaire. I'll keep moving on that. Serologies, just the current finding on hypersensitivity antibodies are that you really need to put them in context. They're neither specific or sensitive, and really not routinely recommended. I would say on occasion they can be helpful when you get a positive serology, and that helps you point you to a source that you had not previously suspected. So if you get a positive mold and you can go back and query the patient, sometimes you can find the source. But in general, they're not considered part of the, you know, recommended workup. The autoimmune serologies are, and per the guidelines, the guidelines recommend a CRP, sed-rate, ANA, rheumatoid factor, myositis, and anti-CCP. I think, are you using the ARUP interstitial lung disease panel? Yeah, perfect. So that's what I think you should do, and we pick up quite a bit on that. The problem with that, of course, is that we pick up a lot of sort of
noise.
Yeah, noise, and then sometimes you have to sort out with your rheumatologist whether this is a really significant serology or not. I think that becomes a bit of an art, and the rheumatologist is becoming more and more part of our multidisciplinary discussions and team. So.
Marybeth, could I just interrupt you for a second here?
Sure.
And you can answer this later. This is a clinical question related to exposures. In your ILD world, do you see exposures to fiberglass, for example? I know it's described in the bronchiolitis world, but is there enough of that for you to see? I've been asked this a couple of times by patients that I've seen in the transplant clinic. And have you seen that? Is that something that you ask as well?
I do. It's on the questionnaire based on their employment history, really. And fiberglass is hard because, like you said, it's oftentimes more of an airway disease based on some of the fumes. And it's hard to nail it unless you get a biopsy, which is going to show some of the bipharyngent. But yeah, we query it. It's queried.
Thank you.
Yeah. So radiology, just to go briefly, I can't remember, do you have a radiologist that you like to work with, a nice thoracic radiologist?
We have had a couple of education classes for our radiology department. It has gotten better. We're currently doing overreads with Dr. Lynch at National Jewish.
Oh, is that how you do it? Okay, great. So you're in great shape then. You've got a, so you just send them to him and he'll do an overread?
Yep. They charge the patient, I think, $50 if we're stuck. But we tend to run both of them. My partner and I tend to run cases past each other, and between the two of us, we're decent if we're stuck.
Good. Okay. Then I'm going to brush through this too in the interest of time. Basically, you know that the UIP probable indeterminate alternate. Okay, great. So using that to guide you on a CT scan is helpful. Let me just talk briefly about a multidisciplinary discussion. It's funny, I've heard Stephen Nathan say that MDD stands for most don't do, you know, because it's just kind of like, it's this really aspirational idea that you could always, everyone would have time every week to sit down in a room and talk about all the cases of the week. And you would have, you know, expert radiologists, pathologists, whatever available. And a lot of us do that. I mean, we'll do that with our radiologist, and virtually bring in the pathologist, or the rheumatologist will come for interesting cases and so on. But I think and I don't know that you actually can do this in a real-time setting. Do you do this in a real-time setting?
We currently are not. Ours tends to be, we're eating lunch in the break room, we pull up images and chat.
Yeah.
So we're both employed by the hospital. We do employ a rheumatologist. They're recruiting a second. So if that happens, they're going to move us into the same office section. And so we'll be able to do that more formally, hopefully.
Yeah.
But trying to get radiology and path to attend is a little dicey.
Right. So I think what happens in the real world is I think people are doing MDDs in their own way, right? But it's sort of like you're the central gatekeeper, and you're bringing in the radiologist, putting that conversation, having a pathologist, and you're putting all this together and ultimately coming up with a diagnosis. So I think even though you don't have a formal MDD, it's good to remember that you're taking the input from the clinicians, radiologists, and pathologists, and also rheumatologists, occupational health experts, transplant, which we're hoping that we'll bond you to better here, so that these conversations are about, through all these experts. And even though you're not sitting in the same room, you're basically putting those pieces together to integrate this data and come up with a diagnosis. And what's important about this, understanding this process, is that these diagnoses are not always so cut and dry. And sometimes you just come down to an MDD consensus to say, this is what it is. And so I think that takes the burden off you a little bit, to understand that you've got a team around you to say, even though it's not clear cut, okay, we're just going to come down on this diagnosis. So,
and our path is not red here. It is, but all the lung biopsies go to Mayo Scottsdale for an ovary.
Yeah, and I'm sure you call the pathologist when the reading is confusing, and yeah, exactly. Right, and then those conversations, as sometimes then you put it together in that conversation. I think this is how I'm gonna call this, right? So yeah, so that's the value of that. But that also really highlights to all of us how complicated this diagnosis can be, and how we don't have perfect buckets for everything, and sometimes it ends up in this category. And even at the end of the day, if you look at ILD series, 10 to 20% become undiagnosable anyway. They become non-classifiable or something like that. So that's a real entity. That's a real diagnosis. So, okay, so good. And then the pathology, which I won't spend a lot of time on, only to say that we, just to think a little bit about how we make decisions to do the surgical lung biopsy. And I think it's really interesting that the guidelines put that the MDD is in the algorithm before the surgery, so that you can have this discussion about your pre-test probability before you send a person to VATS, right? So if someone else in the room can help you make that diagnosis, and you save the patient, the biopsy, that's a very valuable exercise. And so the discussion to send someone to surgical lung biopsy, like so many things we do in medicine, is a risk-benefit discussion. Are we going to get benefit? Are we going to get a diagnosis so we can treat? And what's the risk of this patient? And so understanding the features that are going to make it more probable that you have a diagnosis, i.e., is this IPF and I don't need to prove it by biopsy, makes you a better clinician and less needy of a biopsy. So you probably know a lot of this data, but looking at these features that enhance the likelihood of IPF is someone that's over 60 years old, a male, someone who's Caucasian, a smoker in the past or present, again, no exposures, no connective tissue disease, and a family history of ILD also actually portends a more likely IPF diagnosis. So if you're looking at a patient and trying to decide where you're headed, knowing these factors can be helpful in maybe not doing that biopsy. And as you probably know from the white paper data, when you can make a more confident diagnosis of IPF without a biopsy in the right clinical context of someone who's age over 60, no significant exposure, no collagen vascular disease, and even when you have a CT scan of probable UIP, right? So that's been kind of a shift over the years, that we don't need to have that honeycombing. We can have the probable UIP in the right context, make that diagnosis, and not proceed with a biopsy.
Well, the progressive fibrosis indication has helped us a lot.
And that's helped a lot. That's true. That's true. That's true. And then this is the guidelines about when you do have a biopsy, how you put together, and I'm sure you've seen this, so I'll skip over this. And I just want to briefly mention BAL because I think that question comes up a lot. It is suggested in the guidelines that it's something you can use. Remind yourself that the evidence of recommendation was very low quality. So, you would use a BAL judiciously. But when you have a suspicion, particularly or a possibility of eosinophilic sarcoidosis or infection as part of your risk, that is a general agreement that a BAL would be appropriate. And guidelines forthcoming about hypersensitivity also hedge a little bit on the fact that sometimes lymphocytes, when you have the right clinical context, can help shift you over to hypersensitivity diagnosis as well. So using it for hypersensitivity, understanding that context also can be a helpful diagnosis using the BAL. The other thing that I think has come to the forefront, and I don't know whether you're doing this, are you doing the genomic classifier? Do you have access to that? So this is this Envisia. It's a Veracyte test called Envisia, and it introduces this concept of molecular UIP. So these are RNA sequencing data that they get, and they have a profile, and if patients fit this specific RNA sequence data, then the patient would have, can distinguish UIP from non-UIP. The test is fairly good. It's not fantastic, but it has an 88% specificity and a 70% sensitivity. So it was trained to be more specific to help you tease that out. And so I think it's a test in the right, right setting that can help you obtain more information, maybe make you more confident of a UIP diagnosis, particularly when a surgical lung biopsy is not a feasible option for a patient. So I use this in patients that are higher risk. And I also use it in patients that I think maybe have UIP, but don't quite fit that 60-year-old male, blah, blah stuff, and maybe are a little early in their diagnosis, and we can maybe move that towards getting a UIP diagnosis. So you can, Veracyte would be more than happy to get you set up with that testing, and you do it off of a transbronchial biopsy. So that's
so Marybeth, standard transbronchial or cryo biopsy?
Standard, not
okay.
cryo. Yeah. Standard.
Thanks.
So that's another tool that you can consider for helping with that diagnosis. So pharmacotherapy, and I'll skip to this. You know about pirfenidone and nintedanib, right? Questions about that at all? I can skip that. You know about liver.
The only question I have is, in the last 3 months or so with the progressive fibrosis, we're writing a lot of OFEV. And we're seeing quite a bit of photosensitivity. Do you see that there as well, just with the sun exposure?
With OFEV? I can't say I've seen sun sensitivity with OFEV.
I've probably seen 3 or 4 cases of it with really impressive rashes. One lady with horrible burns. We get so much sun here, and it just wasn't something that I had been consenting about. But
yeah, no, I agree. That's not something I had. It's not in the labeling. It's not in the. It wasn't in the studies. It wasn't highlighted. So I wonder if our post-marketing experience is going to show that, or interesting.
Yeah.
Huh. No, I don't know about that. Okay. This slide I think is sort of interesting. I don't know if you've seen this study. This was from an Optum database, big claim base with over 8,000 patients. It was an observational study where they looked at patients with IPF and evaluated it for mortality. And it was, I thought it was, this is one of the more convincing studies I've seen that we've always been told it slows progression, but we haven't been clear that it's improving mortality. This study really points to the fact that we are improving mortality right away over the first 2 years of therapy. In this claims-based patients that were on either nintedanib or pirfenidone, so it didn't differentiate between the two. In fact, it was equal efficacy for both. Improved mortality after 2 years of therapy, and also decreased all-cause hospitalization. So I think that a lot of people I think are cautious about using the antifibrotics, saying, well, what's slowing progression? My patient's not feeling better. Is it really valuable? But I think as this mortality data emerges, we're going to be more and more comfortable or actually wanting to use these antifibrotics for patients.
We're pretty aggressive about trying them, but honestly, the patient population is so old. We have a lot higher side effect profile, and a lot of times they can't stay on them.
Yeah. And are you working, I mean, do you feel like you have good support in adjusting, dose adjusting, taking drug vacations, things of that nature? Or is that part of the issue, you think?
It's pretty much our office, and then we're using the nurse educator from the pharmaceutical company.
Oh, so you're using them, and they're helpful to you?
They are, yeah.
Yeah, we work really hard with our pharmacists to do all those things, dose reduction, vacations, are you eating enough, you know, things like that. But there's still some that just can't stay on them. So agree. So no data on early data on combining them, but that's not a recommended practice right now to combine nintedanib and pirfenidone. Using it early. And then of course we just talked about this progressive fibrotic, and we're using a lot of OFEV because of that benefit. We just talked about this too, really setting expectations that this is not a cure. The patient shouldn't be expected to feel better, but you know, but then what we think will help them. And certainly there's some patients that aren't appropriate for these, as we just discussed. So IPF management, this will lead us into Dr. Rahman and Dr. Cahill, is really a multifaceted management, as you know, and this is a little checklist that I kind of use or think about to make sure we're doing all the right things, making sure we're reducing our risk factors when we can, getting patients to be their own best advocates, educating them so they know what to do with their disease, making sure we're paying attention to their comorbidities, which is a big process in and of itself, GERD, sleep apnea, coronary disease, so common in this population, supplemental oxygen, which we spend a lot of our time doing that, right? Getting people on the right oxygen and talking to them about their saturations, et cetera. Vaccinations, antifibrotics, pulmonary rehab. Do you have a rehab program there? Okay.
We do. Yeah, it's very
recommended. Of all of the 2 things that are recommended for treatment guidelines, rehab and oxygen, right? Clinical trials whenever possible. So we, of course, are running lots of clinical trials here in Utah, and I know they are in Denver too. So your patients, if they're willing to travel, have options. The problem is traveling, right? Yeah. I do think that's the next, I think that's probably the next, I think we talked about this, Megan, the next thing that we need to capture is virtual clinical trials. If we're doing virtual visits, we should be trying to do these assessments as much as we can virtually. Mental health needs, taking care of their anxiety and being ready for their end of life issues. And then I think the lung transplant evaluation is what another thing you want to learn about. My bias, and I think Cahill and Rahman will reiterate this, as early is good. Because this disease is so unpredictable, as soon as we get that diagnosis, we should be very quickly moving them to or at least discussing with them whether they'd ever entertain a lung transplant, and then moving them towards that evaluation. And with that, I'll
2 questions before you move on.
Yes,
I'll focus on comorbidities. You have VTE. Are you addressing anticoagulation in these people?
In what sense?
If they've never had a clot, are you putting anybody on anticoagulation?
No. One slide I flipped over was that we know from the Panther, or from the ACE study that we did as part of NIH trials, that Coumadin for IPF is dangerous. It's bad. So, and in fact, there's also some data, which is a little scary to me, that, and it's preliminary, so it may not go anywhere, that when you look at patients on Coumadin that have, for other indications that have IPF, they might be having a little worse outcome. So, but we certainly don't treat empirically with anticoagulation.
If they have already clotted, do you care about which agent they're on?
No, but again, that data that I just talked about, maybe we need to think about that, but no, at this moment, we don't have any data that says one's better than another.
Are you, for pH, are you doing annual echoes or every couple of year echoes in your IPF patients?
You know, I aim for annual. Sometimes it's 18 months, you know, kind of thing. But yeah, we tend to watch in the other place we always, I mean, as you know, when someone gets more short of breath, the differential opens up again, right? Is it angina? Is it pulmonary hypertension? Is it, you know, whatever? So we end up getting a lot of echoes as part of an evaluation when a patient says they're feeling more dyspneic. But yeah, I aim for about every year.
Okay. Are you, Marybeth, are you also doing annual high resolution CTs, or your patients, would you just do like PFTs on an annual basis and for less aggressive follow-up?
I do PFTs about every 3 to 4 months to get a sense of stability, but I don't do CT scans necessarily annually. There's no current recommendation of that frequency. I tend to do them for symptom changes, and that's when I'll pull out a high-res CT. And then if I've had a patient that, there's a slight increased risk of malignancies, et cetera. So if I have a patient I haven't had one in a couple years, I'll want to get a follow-up one.
How long after their Q3 month PFTs have been stable do you space them out? Like, are you going after 2 years, after 3 or 4 years? We've got people who have 10 years worth of PFTs that are normal.
Yeah, it depends on the patient.
Okay.
It does. I mean, if I'm following something else, I may do it more frequently. And if they're unreliable, I may do it more frequently. If I have a super reliable patient that watches their saturations every day and they know exactly what they're doing, we'll spread that. I'm exaggerating, but some of these compulsive people that really know about their health versus the person that has no idea would know.
We don't have those here.
You don't have the accountants that bring in the sheet, like with their oxygenation. This is when I was.
Yeah. I talked to Dr. Nathan a couple of years ago about patients who have a family member with IPF, especially ones that had rapid death, but they're young and asymptomatic. Screening.
Yeah.
What do you do? I mean, we talked a couple of years ago. He was saying, yeah, there's a work group that might publish something about it. I haven't seen anything. So
I know. I don't think anyone has published it. I mean, I think screening, and I don't think we know. Well, we put out a statement through the PFF. I was on the writing committee for that about hereditary or, familial, but there's no clear indications. I think most of us would probably do a baseline high-res CT because there is some, you can see the earliest changes, and certainly pulmonary function testing, because if that's abnormal, then you would be more inclined. And what I do is I do the baseline pulmonary function testing, look at that. I tell the patient that if you really want to, what's going to be more sensitive here is the high-res CT, and some opt not to do it and some opt to. And so I kind of have a shared decision-making with that.
Mm-hmm.
And then I kind of want to see them every year, I say, or, and a lot of patients, they sort of fall off. They just come back if they have symptoms. But yeah, that's how but I don't think there's not a set guideline.
Okay.
One other question. What about any of the genetic tests that are out there for, pulmonary fibrosis? Are you doing any of those?
We do it. I do it. So there's not good evidence that you should do it in any sporadic patient. In patients that have familial disease, the recommendations would be that you would have a genetic counselor involved, because of course all the implications of finding out what that is important. And then you do it in the symptomatic patient with disease, not in an asymptomatic family member initially. And then once you can, and there are CLIA certified tests where you can, a battery of tests, the surfactant genes and the telomere genes. And then once you identify that mutation, you could, if there is one, and then remembering, of course, that there's going to be all these variants of unknown significance. So that's where the genetic counselor comes in helpful, so that you can comment on that. And far and away, the most common finding, actually, and even in these familial cases, is these variants of unknown significance. But if you do determine that there's a pathologic genetic mutation, then you can test other family members for that very specific one. Did that answer that question?
Yeah, absolutely. Thanks.
Okay. All right. Great.
This is Barb Cable. I'm just gonna sort of reiterate the importance, at least, or the value that we have found in Marybeth's referring patients early.
Yeah.
In large part because I think it's a daunting concept for somebody who doesn't feel that badly but might have a cough and some exercise intolerance to actually think that they could get bad enough to think about transplant. And sort of hearing about it and considering this gives them time to think about it in a more rational and considered manner. So we have a lot of people in our program that we just defer, and it's entirely because they're referred early, and then we chart stock them until things change one way or another, or until we get a call from Marybeth. We've been transplanting patients here since 1996. Sanjeev joined me in 2009, and it's been the Barb and Sanjeev show here for quite a while. More recently, we've got a great CF doc that just joined us. So, the spectrum of diseases that you're seeing, interstitial disease, obstructive airway disease, sarcoid, occupational disease, CF, and pulmonary hypertension are generally the big groups in which we're finding our business. And I thought I might just have Sanjeev talk to you a little bit about our program And if there's anything that we can do to facilitate your taking care of patients down there, we'd be happy to help you. Sanjeev?
Okay, so hey,
I'll
Jared,
stop sharing. Yeah.
sorry,
you're-
Marybeth, do you have any other slides to finish up with?
Nope,
or
nope.
Are you good? Okay.
Good. So you're
Like,
share.
yeah, I've got a few slides and mostly as just a general framework to talk over. And so please feel free to ask questions or interrupt. Or if my diction is not clear because of the mask, I'll try to pull down the mask. So, but anyway, Jared, may I take control of the slideshow?
Sure.
So,
You should be all set and good to go.
are you all able to see
No.
the PowerPoint here?
You see that share screen at the bottom of your.
Yeah, you
Okay,
have to get
hold on
to.
one second.
Yeah, down the bottom of the screen, there's a green button that says
Give me
share
green.
screen.
Yeah, give me 1 second.
Mhm.
And I have to
He's hanging
say
out in his garage.
share screen.
Here.
Yeah, there we go. Share screen. Sorry.
Got it.
Yeah.
Do you see it now?
No.
So you'll have a share screen button, and then it brings up a list of programs you can
Ah,
find.
there we go. Hold on 1
We
second.
should have every month or two, every 6 weeks, we have a lunch, or we bring lunch in, and we just have multi-brings about it.
Okay.
There we go. Good job.
Now you should be able to see it. And
Just don't- Yeah,
we're-
Looks good.
right.
Yeah. All right. So can you all see the slides now?
They are microscopic.
Oh, wow. Microscopic.
Really?
Wow.
Look good here.
Can you change your, are you playing Hollywood Squares? Is that what you have on your end?
Yes.
We're all, okay, so up in the corner, there should be a
Speaker view.
speaker view
No. Is that right?
that's for her.
For her.
No, we have host a meeting, join a meeting, and that's it.
Oh,
Okay, so right now you're seeing the people in the meeting, and you're seeing a small version of the screen.
Well, now that part's gone.
Let's see.
Okay. So if you will take your mouse up on your computer, go all the way up to the top, and you want to look for something at the top that says View Options.
this isn't you, this is because Marybeth's got it.
What's that?
You have it, Marybeth?
I have it, but there's a different view on mine now. I can see it.
Is it microscopic?
No,
Okay.
but we can see all of us really well, and I think there's a better way to blow it up. I don't know how to. So
Because I'm
There
full screen.
is. Up at the top, if you hover your mouse around, then what you want is to find something that says View Options. You might see a green little box that says you're viewing Sanjeev Raman's screen.
oh yeah, view options at the
And
top.
change that so that it's side-by-side mode. And there in Grand Junction, you're still seeing the microscopic screen?
Yeah, we still have it microscopic here.
Okay, all right. If you take your mouse and hover up to the top of the screen, tell me what you see.
So if we're not able to get this, what I can do is I can talk and then I can email you the slides after the fact or while I can even do it right now to your email. It's a PowerPoint. So
That'd be fine.
yeah. So anyway, so any luck with your side on the display? If not, I'll just sort of start up. So
It's weird too, look, 'cause
okay. So
it's
So, I
amazing.
mean, so when we think about, patients that
That's it.
get referred to us, as Barb mentioned, there's a, large variety of patients with multiple pulmonary diagnoses that get referred. ILDs are probably the most common diagnosis for transplant in the US. Worldwide, it's COPD, but here in the US, COPD is probably the second most common.
If you click
And then
here, it says-
CF is a close third. And then other things like sarcoid, pulmonary hypertension, they're much less, probably in the single digits. So if you think of ILD, it's probably about 30, 35%. COPD about the same, and about 25% of our patients are CF, and maybe 5 to 7% are PH, and other sort of rare or so-called orphan lung diseases, Langerhans, and so on and so forth. I think the big thing sort of is that when people are sent to us or referred to us, there's two pieces to it. Obviously, there's the decision that you as the referring clinician make when to refer a patient to us, and then there's the listing decision, which is connected but distinct from your referral decision. And I think I'll at least initially focus on sort of the referral decision. And generally speaking, when we talk about referring patients, whichever model or survival prediction model you use, we're generally looking at someone who might die within a year or two if they don't receive a transplant. That's sort of my very sort of 30,000 foot way of looking at when to refer a patient. And then I'll briefly talk about, for example, the board index, and we'll talk about some of the things from the ILD world. I'll let Barb talk about some of the CF related modeling and so on and so forth. When we see people in the transplant clinic and we're considering them for transplant, we generally want them to have single organ dysfunction. That's sort of the bottom line. We're looking for someone who obviously is pretty debilitated from their pulmonary disease, but not so badly off that they're moribund or bedbound necessarily. Someone that still has functionality, that's maybe on oxygen, able to do pulmonary rehab. And generally speaking, we don't want them to have a whole slew of other non-pulmonary diseases. There are some what might be considered absolute contraindications, and they're sort of intuitive in that if you got someone that's got very severe, for example, LV dysfunction or atherosclerotic vascular disease that's irreversible, that's probably a absolute contraindication for lung transplantation from our side. Now, it shouldn't necessarily prevent you from referring them to us. Other pieces that sort of give us pause are obesity. Now, that's a bit of a moving target because we know that the population of the United States is getting heavier if you look at the data, sort of the demographic data that's there. So 30 to 35, if you have a patient that has a BMI between 30 to 35, that's sort of a gray zone. But generally speaking, if you look around the country, people with BMIs above 35, it's very hard to actually find a transplant center that will transplant them. The reason for this is related to obvious practical sort of operating upon the chest. There are some data from published reports that actually show worse short-term and intermediate-term outcomes in patients who have sort of the extremes of BMIs. So either extremely underweight with BMIs less than 17 or extremely overweight with BMIs above 35. The approach that we take is, and this is where that sort of that early referral I think is important. If there is a patient that has a lung disease that requires transplant by your estimation, and maybe there's a weight issue, either too high or too low, I think it helps us say, look, we think this is a problem. Either you got to gain weight or you got to lose weight, and sometimes getting people plugged into systems. So I guess one of the things that we see sometimes, in some of the patients at Marybeth and we share, have some obesity, and so then we have to work with a patient who has poor functional abilities, and how are they going to lose weight? So at least here at the U, we've got this bariatrics program that we can medical bariatrics that we can refer people to, and it's sort of a multi-pronged approach to dealing with weight, which gives us several months to sort of work on that, so that the patient's not having to deal with that plus the decision of transplant all at once. So that's sort of just a little bit about the obesity part of it, or the extreme underweight. Barb, any?
No. Other than there has been a shift in, even we're willing to look at short-term strategies to get people down where they can get through an operative phase and a post-operative phase. and then back to dealing with what is going to be a lifelong challenge.
Right. And realize that all the stuff that I'm talking about is based on guidelines. These are not sort of set in stone, large clinical trial data or anything like that. They're oftentimes expert opinion and guidelines put out by the International Society of Heart Lung Transplant. Other things, if we have patients that have active malignancies, so someone that has, say, breast cancer or lung cancer, those are sort of those will usually put the stop on transplant. Patients that you might see as pulmonologists, like a cystic fibrosis patient with a Burkholderia sepacia 3, Genoma 3, that typically tends to give us pause. There are some centers around the country that will transplant those patients, but those are, they tend to be poorer outcomes, etc. Other things.
Can we go back to that? This is a bit of an emerging problem. You guys have a lot of M. abscessus showing up in your community?
No, not really.
Yeah, it's starting to show up here, and I think it's kind of, in my mind, it's the new TB, just because it's so difficult to actually clear, and I think it's a bit of a moving target for consideration for transplant, but put it on your horizon.
The other things, I mean, we want, patients who get referred to us when we're thinking about them as transplant candidates potentially, they've got to be free from drug use and, generally speaking, not heavy alcohol consumers. Recreational marijuana is a bit of a moving target, again, because of the shifting federal and state laws surrounding it. But it should not be something that is all-consuming. That would make that a challenge for transplant. And then the biggest piece, I think, is for patients to be able to relocate for a period of time with a caregiver, which I think tends to be, especially when we're talking about moving 4 or 5 hours away for, several months at a time. We can talk about that. Yeah.
When you talk to them about moving,
I
was in training, we always told them plan for at least a year. Do you have a ballpark where you say like you're expected to be there for a time period?
Yeah, about 6 months, I'd say. Average 3 before and average 3 after, with an approximately 2-week hospitalization. So 6 to 7 months is probably the number that I give. And of course, there's variations to that theme, and a person who gets complications or doesn't, and so on and so forth. So.
And I think it makes a difference if you've got a sort of a place they're going back to where you're trustworthy, that you've got a trustworthy co-management partner.
Yeah.
That makes a huge difference in terms of when people can go home, because I do realize that it's a total disruption of their lives.
Yeah. You didn't mention age, and most of our patients are significantly older.
Yeah.
so
there's no real. Yeah. So there's no absolute sort of upper limit, just because I think by law, I don't think we could do that. But generally speaking, you get into sort of slightly tricky territory in patients above 65, just in terms of risk of the procedure and immune suppression and so on and so forth. However, having said that, we have several patients that we've transplanted over the last, 7 to 8 years almost now, that have been in their upper 60s. We've transplanted a few people in their early 70s. But again, generally speaking, these are people who are otherwise, just single organ dysfunction, and they're fit by every other account. So, and they've got to be, rehabable, quote unquote, put them through a pulmonary rehab program and improve their 6-minute walk distance and functionality and so on and so forth. That becomes a little tricky if you got a person on a vent who, say, for example, has an ILD flare and lands up in your hospital and says in their mid to late 60s, it becomes much more risky. So, age, again, sort of, it depends on the context. So, yeah.
We're pretty comfortable looking up to 70 and then looking hard after 70.
Yeah, and we'll do case by case. I mean, we don't have an absolute cutoff. The one thing that probably comes up a lot is, your patient who has bad lung disease, pneumothorax, maybe pleurodesis, or someone that's had a bypass in the past, etc. So just to be very clear, even a CABG in the past is not an absolute contraindication for lung transplant surgery. We can, in certain selected patients, perform a single lung transplantation if they don't have pulmonary hypertension. Pleurodesis, it becomes technically challenging for the surgeons, but it's not an absolute contraindication. And then the other piece that comes apart, comes up is pneumothorax. And I think our general sort of philosophy is manage it as you would manage it today. And to a certain extent, don't think about the lung transplant that may happen 2 years down the road, because we'll make those decisions at that time. So,
Right.
yeah. I'll sort of skip through some of the ILD stuff because, I've got slides with Marybeth's covered a big part of the ground. But, basically the people with IPF that, and I'm talking about IPF because it's the worst of the ILDs, as she mentioned, but people who are older, typically more honeycombing on their imaging, these are probably the people that have poor prognosis, and early referral should be considered in those patients, especially if they've had acute exacerbations and have needed to be hospitalized. When you see your ILD or IPF patient over time, if they're getting worse with their dyspnea, they're dropping their vital capacity by 10% or greater over, say, a 6-month period, a decrease in their diffusing capacity, a worsening of their fibrosis on CT scan, those would all be guidelines to suggest considering referral to transplant. 6-minute walk distance dropping would be sort of a surrogate for all of this.
I think our bigger issue really, Dr. Woodson and I have talked about this a lot of times, we're not seeing people who are 70 and younger. I mean, our ILD population, we're getting referrals of people in their 80s, late 80s, early 90s with ILDs. And so I would love to see somebody who is 58.
Yeah, right. Yeah,
I'll send it to you, but I don't know if I have a patient that young.
The hard part about it, I can just sort of speak to our experience, of course, but I can sort of reflect even the national experience. And you'd be hard pressed to find a significant number of patients in their late 70s and even into their early 80s, even in the most aggressive of programs.
Transplant programs.
Agree. And I think that's why it was so important for us to hear from you guys, like the perfect transplant referral, which is great under 65 and skinny. I'd love that, but
65 to 70.
On the off chance that I ever find that, what part would you like me to do before I send them to you, and what do you want to do there?
Right. I'll skip through some of these other slides. And the one thing which I will mention is, and this is quite intuitive to pulmonologists and ICU clinicians, is if you have an interstitial lung disease that gets bad to the point that it lands you in an ICU on a ventilator, as it is, the mortality from that is quite high, and the prognosis, even short term, is quite poor. So that would be someone that would, probably give us absolute pause. Now, there are, of course, exceptions to this rule. There's a younger patient who has no other comorbidities, etc. But that it increases the risk of poor outcomes in that patient. So we are duly concerned about such patients. So I think that's another sort of argument or plea, if you will, for early referral before they get to that acute exacerbation landing up in the ICU. So, just briefly about pH, and as you are all probably aware, pH, when added to any lung disease, especially interstitial lung disease, is a worse indicator of survival or portends a poorer prognosis. So this would be, again, someone to think about referring to transplant a little more strongly if they had developed pH for one reason or other. I'll skip some of these. So emphysema, do you have a big proportion of either occupational emphysema or smoking related emphysema? What are in sort of Grand Junction area? What's the general sort of prevalence of smoking in that area?
Mostly smoking. I would say mostly smoking.
Mostly smoking. Okay. Yeah. I think Utah is a little different. We have about 4 or 5% prevalence of smoking compared to some 18% nationwide, is what I understand. But anyway, when we think about emphysema, that's another sort of big category of people that get transplanted. And again, these are people that are typically 50s, 60s, that we typically see. The alpha-1 antitrypsin is an exception to that. It's the younger patient, as you know, and oftentimes with not a obvious or significant smoking history. When we see these patients, they're the tricky ones because you've seen your COPD who sort of plugs along for years and years and does their inhalers and is really short of breath. But there are a few things that, at least for me and based on sort of the published literature, give me pause. And that's the patient that either has cor pulmonale or developed cor pulmonale, a patient that's frequently exacerbating and getting admitted to the hospital, and someone that's got, for example, hypercapnic respiratory failure, either requiring invasive mechanical ventilation in the ICU in the hospital or non-invasive respiratory assist device support as an outpatient. For me and for us, I think when we think about those COPDers, they're sort of like the, I guess what's the reverse of cream of the crop, but they're the worst of the lot. Right, they're the worst of the lot. But the point is they're the most, yeah, the most sick, let's say, for whatever that term means. But they're the ones that I think are, you know, when you see your average COPD, if you got one of them that's meets those criteria, that's probably a person to think about. We do use the board index to a certain extent in sort of helping us make these triage decisions. The board, as you know, doesn't capture, you know, need for mechanical ventilation, etc. And as you all know, it's 4 things. It's the body mass index, it's the FEV1, it's the dyspnea as measured by the MMRC scale, 1 through 4, and then it's your 6-minute walk distance. So you get a composite score, you score it between 0 to 10. Anyone that's in that 8 to 10 points on 10 is in the highest quartile, and they probably have the worst 4-year survival, about 15 to 18%. Those are definitely people that we transplant. But when you're thinking about referral, even someone that's got a calculated board score of 5 to 6 is probably someone that you would think about referral. Now, granted, these are all guidelines, and the caveat to this is that the board, as you all know, was not validated, neither designed to look at referral decision making for transplant. It was just a prognostic tool for COPDers, and it was an international cohort. So Venezuela, United States, and one other country. But the point is, we use it as a sort of a soft indicator, let's say, for referrals, and it has actually made it into the ISHLT guidelines. I'll skip through sort of details of the bold score in the interest of time because all pulmonologists probably know